Welcome to the deep dive. Today, we are taking one of the most essential clinical resources, cracking it wide open, and just delivering the highest yield facts directly to you.
We're aiming for maximum clinical efficiency.
Absolutely. We're plunging right into a cornerstone for medical students, for young professionals, Deja Review Obstetrics and Gynecology, second edition.
That's exactly right. And our mission here isn't just to, list a bunch of facts. It's to give you a synthesized, really targeted review of the core concepts you absolutely need to anchor your knowledge.
So we're talking core procedures, anatomy, endocrinology.
All of it, the major gynecologic pathology, and of course the non-negotiable maternal-fetal physiology. We're distilling it down to the essentials.
And as we go, I think there's a really critical theme we should keep in mind: timing and risk.
Oh, absolutely.
I mean, in OBGYN, when you do something, dictates the risk. When a hormone pops up, dictates the physiology. And when you diagnose something, that dictates the entire outcome. We'll see that everywhere.
That's a perfect frame for this. Let's start there.
Okay, let's unpack this with a look at some common procedures, starting with fetal diagnostics. If our theme is timing and risk, then this choice is the perfect place to start.
It really is.
We need the essentials. What is it? When do you use it? And how does that timing affect the baby's risk?
Excellent question. So the three big ones are chorionic villus sampling, or CVS, amniocentesis, and then percutaneous umbilical blood sampling, which we usually call PVS or cortocentesis.
And CVS is the earliest one.
The earliest, yeah, typically done between 10 and 13 weeks for genetic analysis. The early timing is its big advantage, but that also changes the risk profile.
Meaning the risk of fetal loss is a little bit higher.
Exactly. CVS carries a slightly higher rate of fetal loss compared to the procedure that comes later, amniocentesis.
And when is that done?
Amnio is done after 14 weeks. And because you're doing it later, the risk drops. Its uses are also broader. I mean, we use it for genetics, sure, but also later on to check fetal lung maturity or look for an infection.
Okay, and then there's PUBS. That one just sounds like the highest stakes procedure of the three.
It is. PUBS means we're getting fetal blood directly from the umbilical vein, all under ultrasound guidance. It's invasive.
So you're reserving it for very specific situations.
Very specific. High-risk situations where time is critical. Think severe alloimmunization, or if you need a rapid check of fetal blood gases. It's really an intervention of last resort, when the risk of not knowing outweighs the risk of the procedure itself.
Right. Shifting over to gynecology for a second, let's talk about a procedure that really shows how technology changes practice: coldocentesis. It's not as common, but the clinical lesson is still so important.
It is. Coldocentesis is where you pass a needle into the cul-de-sac. Now, ultrasound has mostly replaced it, but the concept is critical. You're analyzing fluid.
And the findings are immediate.
Immediate. If you get bloody fluid, you have to think ruptured ectopic pregnancy. If you get pus, you're looking at a bad infection like PID. It's a diagnostic shortcut.
Okay, let's clarify some surgical terms. Hysterectomy types. The definitions have to be crystal clear.
Yes, the defining factor is really what gets left behind. A total hysterectomy removes the whole uterus and the cervix.
Okay.
A subtotal, or supracervical hysterectomy, takes the body of the uterus but leaves the cervix in place.
Which can be important for pelvic support.
Precisely. And then you have the radical hysterectomy. That's defined by its margin. It's not just the uterus and cervix. This is cancer surgery.
So you're taking wide margins of the surrounding tissue.
Wide margins, the adnexa, cardinal ligaments. It's all about the extent of the resection.
Before we move on from anatomy, let's lock in that one key relationship that every surgeon has to know: the ureter and the uterine artery.
Ah, yes, the classic mnemonic. It's essential because injuring the ureter is just a terrible complication.
So what is it?
You have to remember, the ureter crosses under the uterine artery. It's water under the bridge.
Water under the bridge. Got it.
And this crossing happens about 2 centimeters lateral to the cervix, right in the cardinal ligament. Misjudge that, and it's a disaster. You have to have that anatomy internalized before you even start.
Okay, so let's shift from physical structures to the hormonal timing mechanism, the endocrine clock. This is where it gets really interesting. We all talk about the HPO axis, but what actually drives the variability in cycle length, and what part is totally predictable?
The whole system starts with pulsatile GnRH from the hypothalamus. That hits the anterior pituitary, which then releases FSH and LH.
And those hormones talk to the ovaries.
Right, which then secrete estradiol, progesterone, and inhibin, which in turn provides that negative feedback to FSH. It's a complex loop.
It sounds like it.
But here's the key to the variability you asked about. It's the duration of the follicular phase. the part driven by FSH that dictates the total length of the cycle. That phase can be really different from person to person and even cycle to cycle.
Wait, so if the follicular phase is the variable one, that must mean the luteal phase is the constant.
That's it. That is the critical stabilizing factor. The luteal phase is remarkably constant. It lasts 14 days.
Always 14 days.
Always. It's maintained by the corpus luteum, which is pumping out progesterone and estradiol. That consistency is what lets us pinpoint ovulation timing.
And those two hormones, estrogen and progesterone, they have really distinct measurable effects, don't they?
They absolutely do. When estrogen is dominant, it stimulates thin, watery cervical mucus. If you draw it on a slide, you get this beautiful classic ferning pattern.
And progesterone does the opposite.
It reverses it. After ovulation, progesterone thickens that mucus, makes it sticky and stringy. We call that Spinbarkite. And critically, it also raises the basal body temperature by about half a degree to a full degree Fahrenheit.
Which is the whole basis for natural family planning.
Exactly.
Okay, let's pivot to contraception. We need to talk about the difference between theoretical effectiveness and, actual effectiveness, the real world.
This is so important for counseling. Knowing the typical use failure rates is non-negotiable. For something like an IUD, LARC, the failure rate is incredibly low, like 1%.
Which is amazing. But then you get to oral contraceptives. They work great chemically, but people forget to take them.
That's the problem. OCPs fail at a rate of about 10% in typical use. It's a huge jump. A great method used imperfectly is not a great method. And then compare that to something like withdrawal, which can fail up to 30% of the time.
Wow. Okay, so speaking of OCPs, let's zoom in on the main risk. The benefits are lower cancer risk, less PID, but what's the big thing to watch out for?
The primary risk, the one we screen for carefully, is the increased risk of thromboembolic disease and stroke.
A blood clot.
Right. And the mechanism is pure endocrinology. The estrogen in the pill stimulates production of clotting factors, specifically 7th and X, and at the same time, it decreases antithrombin the 3rd.
So you're pushing the gas on clotting and taking your foot off the brake.
Perfect analogy. It creates a hypercoagulable state.
But what about other drugs? I know some can interfere with OCPs. This feels like a major clinical error point.
It is. You have to ask what decreases OCP effectiveness. They're metabolized by the cytochrome P450 system in the liver. So any drug that induces those enzymes will chew up the hormones faster.
Like what kind of drugs are we talking about?
Some anticonvulsants, like phenytoin. Certain antibiotics, like rifampin. They speed up metabolism and decrease the hormone levels in the blood.
So if your patient needs one of those drugs, hormonal contraception is basically out, no matter how well they take it.
Precisely. In those cases, you have to pivot your counseling. You strongly recommend non-hormonal methods, and the copper IUD is often the best choice because it works locally, completely separate from all that.
Okay, let's move into some key pathologies, a big clinical challenge. Ectopic pregnancy versus a viable intrauterine pregnancy. The key seems to be the beta-HCG level.
Yes. The marker that governs this whole diagnostic tree is the discriminatory zone.
The what now?
The discriminatory zone. It's a specific range of beta-HCG, usually around 1,500 to 2,000. Above that level, you must be able to see a gestational sac on a transvaginal ultrasound if it's an IUP.
So if the HCG is above 2,000 and you see nothing in the uterus...
You have to assume it's an ectopic pregnancy until you can prove it's not.
Okay, but what if the HCG is low, below that zone, and you don't see anything? What's the next move?
You repeat everything in 48 hours, both the ultrasound and the beta-HCG. For a viable IUP, that HCG level should basically double. If it doesn't rise like it should, that points to a non-viable pregnancy, either a failing IUP or an ectopic.
And if you do confirm an early ectopic, you can use methotrexate, but there are a lot of contraindications.
They're very strict. You can't use it if there's active bleeding, if the pregnancy is bigger than 4 centimeters, if the patient is breastfeeding, or if they have liver or renal disease. It's just too risky.
Got it. What about gestational trophoblastic disease, or GTD? What are the red flags for that?
You usually suspect it after something strange happens following a pregnancy or abortion. So unusual bleeding, a uterus that's way bigger than it should be for the dates, or beta-HCG levels that are just sky high.
And there are two main types, the complete and partial moles. How do you tell them apart? What's the key difference?
The single biggest difference is the presence of fetal tissue and the ploidy.
Okay.
The complete mole is diploid, has 0 fetal tissue, and has a high malignant potential, maybe 15 to 25% risk of becoming cancer.
And the partial mole?
The partial mole is triploid, and it does have fetal tissue present. Its malignant potential is much lower, maybe 5 to 10%.
Mhm.
So if you see fetal parts, you're looking at a partial mole.
Simple enough. Last one in this section. Pelvic inflammatory disease, or PID.
Yeah.
Why is getting this diagnosis right and right away so important?
Because of the long-term damage. PID causes scarring in the fallopian tubes. It is the most likely cause of tubal factor infertility in a normally menstruating woman under 30.
That's huge.
It is. And it also dramatically increases the risk for chronic pelvic pain and future ectopic pregnancies.
And the presentation can be tricky. There's that strange complication, Fitzhugh-Curtis syndrome.
Right, FHC syndrome. It's basically a perihepatitis, inflammation around the liver capsule, so it causes right upper quadrant pain.
Which would make you think it's a gallbladder problem.
Exactly. The crucial takeaway is that RUQ pain does not rule out PID, and because it's a polymicrobial infection, you have to treat it with multiple antibiotics to cover everything of gonorrhea, C. trachomatis, and anaerobes.
All right, shifting to obstetrics, let's talk about how the maternal body adapts. The changes to the cardiovascular and respiratory systems are just massive.
They're staggering. Cardiac output goes up by 50%, blood volume goes up by 50%, but interestingly, blood pressure usually goes down a bit.
And positioning matters, right?
Massively. Cardiac output is maximized when the mother is in the left lateral decubitus position lying on her left side. It takes the weight of the uterus off the inferior vena cava and lets blood return to the heart.
Such a simple intervention with a huge effect.
And what about breathing? That's driven by progesterone. It increases the drive to breathe. Tidal volume goes up 40%, minute ventilation by 50%.
So she's breathing more. What does that do to her blood gases?
It leads to a compensated respiratory alkalosis. She's blowing off more CO2, so the kidneys compensate. And her pH stays in a really tight, slightly alkaline range, around 7.40 to 7.45.
Okay, let's nail down some definitions. Gestational age.
You need absolute clarity here. First trimester is less than 14 weeks. A pregnancy is term between 37 and 42 weeks.
Then after that?
Anything over 42 weeks is post-term. And that requires much closer monitoring because of risks to the placenta and the fetus.
What are the key anchor points for antenatal testing?
So the timeline is key. The first trimester screen with the nuchal translucency, that's done at 11 to 13 weeks. Glucose screening for gestational diabetes is done at 24 to 28 weeks.
And the GBS swab.
The Group B strep culture, that's at 36 weeks. It determines if she needs antibiotics during labor.
Okay, let's talk about the ultimate test for fetal well-being. The biophysical profile, the BPP, what are the 5 parts and how do we interpret it?
So the BPP scores 5 things out of 2 points each for a total of 10. You've got the non-stress test, fetal breathing, fetal movement, fetal tone, and amniotic fluid volume.
And there's a hierarchy there, isn't there? As a fetus gets more hypoxic, things disappear in a certain order.
There is. They drop off in reverse order of how complex they are.
So what's the last thing to go? The most resilient sign?
Fetal tone. Tone is often the last sign to disappear when hypoxia is acute. So if you lose fetal tone, that's a very, very bad sign. The NST is usually one of the first things to look bad.
And the score. 8 to 10 is good.
8 to 10 is reassuring. But a score of 0 to 2 means severe fetal compromise. That requires immediate delivery no matter how far along the pregnancy is. The fetus is actively failing.
Wow. Okay, finally, let's touch on the principle of teratogens, again, focusing on that timing of risk.
The question is always, when is the risk for major structural defects highest? And the principle is that exposure in the first 8 weeks results in embryopathy.
Because that's when all the organs are forming.
Exactly. That's the period of organogenesis, so you get major structural malformations. After 8 weeks, exposure results in fetopathy. That tends to cause functional defects or minor malformations, not big structural ones.
Can you give an example?
Sure. An ACE inhibitor used later in pregnancy can cause kidney problems. Isotretinoin, or Accutane if used early, causes devastating craniofacial and neural tube defects. The when determines the what.
So what does this all mean for the learner? We covered so much ground, from high-stakes procedural timing to the hormonal dance of the menstrual cycle, all the way to that BPP score. The theme of timing and risk was everywhere.
It means you now have that foundational high-yield knowledge for confident clinical work. So let's reinforce one of these ideas with a quick review question.
Let's do it.
Okay. A 24-year-old sexually active female presents with fever, lower abdominal pain, and cervical motion tenderness. You're treating her as an outpatient for PID. What's the standard first-line antibiotic regimen, And what's the primary reason for needing multiple drugs?
Okay, the standard outpatient regimen is ceftriaxone plus doxycycline, sometimes with metronidazole. And the rationale, which is the whole point, is that PID is polymicrobial. You have to use multiple agents to cover everything, the gonorrhea, chlamydia, anaerobes, to prevent that long-term damage like infertility.
Excellent synthesis. Okay, for a final provocative thought, think about that interconnectedness. What additional complications could come up from that simple PID diagnosis that would force you to admit her to the hospital for 5E treatment and pose the biggest acute threat to her future fertility?
The big ones would be suspicion of a tubo-ovarian abscess, or TOA. That needs aggressive IV treatment.
Oh,
Or if you can't rule out a surgical emergency like appendicitis. Or simply if she's not getting better on oral meds after 72 hours. All of those would require a shift to inpatient management to save the tubes.
that's exactly right. That's a wrap.
That's a wrap on our deep dive into the essentials of obstetrics and gynecology.